As many of you know, Anne is a psychiatrist and is someone who worked in the trenches for many years, wearing many different hats over the course of her career. And immediately prior to coming to the Office of Mental Health, had an instrumental role at HHC in doing readmissions work on the medical side, and learned a lot of lessons that I think are applicable here for mental health. And so we're really pleased to have her come to us with that expertise and to share it today.
Hi, good morning, everyone. It's really a pleasure to be here. And I'm going to be sharing with you first some of what we're trying to do at the state on the system side to help with what I know you're all thinking, especially with me in this position, you know, how do we find housing for our patients, how do we move them, et cetera, et cetera. So I'm going to talk a little bit about that and what I think is the beginning of hopefully a partnership with you to help on that end. And then I'm going to talk pretty much anecdotally a little bit about what I found working on the CHF side. And you know, if you work with congestive heart failure patients, they're tough. They're tough to stop the readmissions. In some ways, they're very much like our patients, and some of it is really very difficult. So I'll be talking about that afterwards. And then I have two examples from your group of hospitals who did great with the readmissions and kind of what it took to do it. And it's certainly not an easy job. So let me begin, first of all, by just talking a little bit. I'm going to go through this quickly, but I often think it's important to frame where this fits in the big picture, because the big picture is complicated. I was just at United Hospital Fund this morning where everybody was talking about dish ribs and, and how we're getting together. Readmissions and unnecessary avoidable admissions are a critical factor in all this, but they're not the only factor in all of it. And where this comes from, and I always talk a little bit about this concept of the triple aim because I think it helps us as we go forward. That basically what we're doing is we're transforming the system of care. We're transforming the system of care from one which is heavily cost-based in hospital systems to one which will ultimately have a lot of those dollars flowing on the prevention and the outpatient ambulatory side, and on preventing, the whole goal of actually preventing admissions, which if we'd said this even maybe 5 or 6 years ago, people would have just looked at you like you were crazy. I mean, what are you up to? I mean, how do hospitals stay alive? They stay alive with admissions. And this is something that I met on a big side, on the medical side, where it was very critical that to keep those admissions coming in, and a lot of thought was not given for decades about maybe they didn't all need to be in the hospital in a certain way until the payers and the feds started to push. The triple aim is the basis of the theory behind the Affordable Care Act. And the Affordable Care Act is much, much more than health insurance. It's a push through the providers, through the feds, through government, to change the way we provide clinical care. And that's an interesting phenomenon. So they're changing the way they're going to start paying for Medicare. They're changing the way we're going to be paying for Medicaid from the state. And the goal here is to really have a different healthcare system at the end, 5, 6, 10 years from now. This has been tried before, those of us with gray hair. But I don't think it's ever been tried with as many initiatives and on as many fronts and with quite the same push from the feds to actually make it happen on the things that the federal government pays for. And so I don't think it's going to go away this time. I think that this is something which is here to stay. I think that's why there's the investment in Discharge, and I think it's going to start impinging increasingly on psychiatry. You know, the reason we picked CHF to work with as the first big readmission collaborative was because the hospitals were getting penalties for CHF. That was the beginning of this concept that maybe you're not going to get paid as much. You could lose, after a couple of years, as much as 3% of your total Medicare revenue if you fell below certain things on this readmission stuff. That's big time money. And that began to get the hospitals thinking about how they have to change what they're doing. And now it's just becoming bigger and bigger between DSHRIP and everything else. But the reality here is, what the triple aim says is there's 3 pieces in healthcare, and they're all equally important. I think that's the critical piece. Prevention, wellness, good care when you need to be in a hospital, and getting the cost at the level it should be. And it's that bottom cost that I think is the most important. And I can honestly say when I was in my hospital system, I was really concerned about revenue. If I kept the money coming in, I could do all kinds of things. I didn't have to worry about it because my margin was okay. But what they're saying here is that's not what we're after. We're not after just expansion of dollars. We're after making sure that what we provide is value-based cost. The next thing it's going to be coming is value-based purchasing, which is basically, if you look at the fine print in DSHRIP, Supposedly within 5 to 6 years, 90%. The goal of 90% of care will be provided in some kind of value-based system. That's a huge change. That's a huge change. So we're in the midst of a lot of change. We're a part of the medical system that's in that change, and I think we have to kind of think of ourselves that way. So I'm not going to spend a lot of time. You can read these if you want to, because I want to get into readmissions, population health, critical. And the only thing I want to say here is that when you think about our patients, when you think about patients with schizophrenia, what's wellness and health for patients with schizophrenia? It's basically getting a job, having peers work with them, making sure that basically they get the kinds of help that they need to live a certain quality of life. And we're embedding that into the Medicaid benefit through the HARPS. So for the first time, Medicaid will pay for education, for help to get patients educated, for employment counseling, et cetera. All this stuff was paid for before by some other source. So embedding it in the healthcare benefit makes a huge difference. So that's a big change. The other big thing embedded throughout is collaborative care, which you're hearing a lot about, I'm sure, through your DISHRIPs. Huge prevention effort, because we all know that very few of our patients actually come, a small percentage of mentally ill actually come to us. When we talk about anxiety disorders and depression, they're all sitting in those primary care clinics, and most of them not getting treatment. Huge prevention effort to do primary care, collaborative care. So, DISHRIP, I'm going to say two things about DISHRIP. The first thing is a lot of money. It seems like a lot of money, but when you start spreading it across New York State, it makes lots of money. And what it's asking for is tremendous. Lowering readmissions and admissions by 25%, I can tell you, really, really hard. So this is not by any means easy, and the whole state's in it. So basically, if everybody doesn't get the certain number down, then for the out years, there'll be less money. And the second big thing about DISHRIP is this value-based purchasing, which is coming down the line, which psychiatry has to start thinking about. We have not been in this ballgame in the same way that the medical side has been. And I'm really just encouraging you to start thinking about it, talking about it. Things like bundled case payments, things like making sure, because, you know, eventually they're going to stop paying for things that go wrong in psychiatry, like they stop paying for things that go wrong on the medical side. You don't get paid anymore for wrong site surgery or certain infections or certain things that happen on the medical side. And you do get bonuses for certain good things. So all I'm saying is psychiatry is going to be brought into this loop more and more. So kind of think about it, get ready about it, start talking about it. That's not for today, but just to keep it there. The reason I always put up this slide is because this is where I'm asking you, if you haven't had entree yet, into working a lot with your medical providers, that where are the preventable readmissions? There's a bunch of them that sit in patients that come from the medical side and go back to the medical side. About a quarter psych and substance use that go back to psych and substance use units, and half are patients with significant substance use and mental health that sit on the medical side. In many hospitals, they're not even seen. They're not even engaged in trying to work with them. And that's where I think what's going to happen is when they try to get these readmissions down, I can tell you this for the medical side, they're going to start coming to you guys because they're going to start to realize that to get those readmissions down, they need behavioral health very much involved on the medical side. Huge piece of this are alcohol readmissions to the medical units, huge. The other piece are patients who are our patients who kind of don't follow through but keep coming back to EDs, keep getting admitted. Huge issue, and you're going to get asked about this at some point if you're not already, because it's going to start to become obvious as they try to lower those readmissions and admissions that there's this group of patients that they can't deal with, and they're going to start to come to you. So I'm just saying, beware, be ready, and have some ideas about what you can actually offer to the medical side of your house. Now, what are we trying to do, and just a minute on this, on the state side to help you with this? We're closing beds on the state side. So I know it's going to be rolling in the room, and everybody's going to say, oh my God, here it comes. But the reality is, as we lower those beds, there'll always be a need for beds. As we lower them, we've got $110,000 per bed that comes down to reinvest in community-based services. And what we're reinvesting in are services that we think, by certain data, show can help us prevent admissions and readmissions, and can also help you. So we're engaging in housing, lots of housing, and housing with wraparound services that we will support through the state and through other grant initiatives to help people stay in that housing. They're a bit more acute than the traditional patient who goes into a supported housing home. Because most patients who go to supported housing that have 2 years in CO, we can't do that anymore. We're not going to be building bricks and mortar. We actually can't because of the Olmsted decision. But we're going to be using more and more supported housing. But to really use supported housing well, you need a system. You need mobile teams that can work with those clients. You need wraparound services, et cetera. So we're in the process of trying to design this. We're in the process of trying to spend some of the reinvestment money that is coming to New York City to deal with some of this. And we're in the process of working with DOH&H about what they want and how we put it in place. So it's not like we're saying it's all up to you. I have a recognition that some of it's up to us on the system side to have the services available for some of those patients, to have beds, housing beds out there, because you can't say that you're not going to readmit patients if they can't go home to a safe place. And we have to kind of work on that. We need a better crisis system in the city. We need one that's kind of easy to access and one that can really get to that patient. Get to that patient maybe in an ED and work with that patient in ED to avoid an admission if you don't happen to have something. We need to think a little differently, and we're going to try to be helpful with that on the state side. And we have a few bucks to do it. Never as much as you'd like to have to do it, but we have a few bucks. So this is just going through that. You can read it a little bit more. The same issue with managed care. Managed care, while at the same time, everybody's afraid of managed care, and I think we have to be very careful. We're trying to do this in a way that makes sense, that we make sure that people get the dollars. Managed care will be expected, that we try to keep people out of the hospital. The long-term thing in that, I think, is what I just spoke about before, which is the HARPS. I think if we do it right, with combination of good clinic services, peer services, good pro services, maybe need to be modified a little bit, more ACT teams or more light ACT teams. We're looking at whether we can have some services that aren't quite as robust for some patients that maybe need to transition out. All those things are getting built in some ways to the Medicaid benefit. And we're going to be working with you to do that. And I think if we can do that right, we can have an impact on how we do it. And actual crisis services, we're trying to get that to be a general benefit as well. And I think we're almost there with CMS that would be acceptable on the general side as well as on the HARP side. So there's a lot of work that we're doing to try to have the right services in place that I honestly think will help with readmissions. So you're not in it alone. And what we're also going to be doing is asking, and those of you who are interested, please join us to have meetings at our regional office here in the city where I'm focusing on two things, working with the housing providers on discharged patients, and the other one is working on the relationships between my state PCs and the stuff that we're doing at the state PCs and the Article 28s. Because I was there. I know how people sometimes feel. I think we need to be able to get the right patients into the state system, and they're not always the right patients that are. We need to be able to go now. So we'll be setting up those things in the regional office, and I hope there's an involvement by you guys, we'll be inviting everybody that you come and help us work together on this. Okay, so now readmissions. I'm going to talk about these points a little bit from my experience with readmissions. And just to start out, we got hit with a significant, we were afraid, and we actually did the first couple of years and then got much, much better, with a significant penalty for this on this medical side. And personally, when I first saw it, and I was actually on one of the measure people with the National Quality Forum, I kept saying that our patients in HHC have too many psychosocial problems. We can't get this down. We can't do this. There's too many things that are beyond our control. But we were getting penalties, so we had to figure out what we could do. And what I can honestly say is we're never going to probably get HHC to be the lowest readmission rate in the country, but HHC hospitals have gotten to be at the average or slightly below the average in getting rid of their penalties. So it's not impossible. Even with the most difficult patients, some you won't be able to maybe stop the readmissions, but much of what's involved in readmissions is within our control. And that's the first cultural issue. I'm going to talk about all these, but let me skip to culture. I think the first, and probably the most important, is this one, that we buy that. That we buy the change, that readmissions are our problem, not the patient's problem. They're the provider's problem. If a patient needs your service and ends up getting admitted in 6 or 7 days, it's not enough to say, oh, they were non-compliant. Oh, they didn't, the housing thing didn't work out. We have to accept that they came back and there's a good shot that something we did wasn't right. And until you kind of buy that and your whole team buys it, believe me, the most difficult readmissions you're still going to not pay attention to because you're going to think they're impossible. You're going to think, I can't prevent that. So the first thing has to be a culture change. And the culture change also has to involve a concept that everybody on the team has a stake in this. It's not the job of the discharge social worker. That the doctor has to be as much involved in at least whenever they have contact with that patient, talking with the patient about what their life is going to be when they leave. You can't think, and I've been in the hospital systems a long time, and basically it's you're very worried about doing absolutely the right thing while the patient's there in front of you. And I actually think we do a pretty darn good job there. I think we do maybe a little more with injectables, maybe some more with Clozaril. Please think Clozaril. It's really very good drug. You know, but if you really, we do a pretty good job. What we don't do a good job is figuring out when we've got that patient at the most acute point, at a point, a true crisis point in their life. How does the materials going to be? And what's our responsibility in helping them do that? And we've shortchanged that fact. We really have. You know, if you think about it, I had a recent family member that was hospitalized for a medical problem. And the whole experience was just mind-boggling. Very scary, very concerned. They got a list of discharge things that they used to what to do. I was sitting there with them. And there were these 10 questions I didn't think to ask until I got home the next day. I said, uh-oh, I don't know. What are we going to do about that drain? What did they say about the drain? You know, I don't know. You know, so basically what I'm saying is these are traumatic experiences for our patients and for their families. You can't underestimate how much doesn't penetrate during that admission and how much has to happen after they leave. They have to have that support after they leave and you get back. Can't underestimate it. So you have to say, getting the right formula for post-hospital is just as important as getting the right care when they're in there. Everybody's responsibility and engagement. And I realized when I did this slide, where did I put engagement on the bottom? And that's a little bit of a Freudian slip, because somehow it always ends up a little bit on the bottom. It should have been on the top. It should have been on the top. If we don't engage patients, and engagement, again, is our problem, not the patient's problem. It's our problem. And please, I had one, my docs that I worked with who did a lot on readmissions, and she said that nobody was ever allowed to ever again say the word non-compliant, because it implied that basically it was the patient's problem. It's got to be a together problem. It's got to be us working with the client. Culture shift, I'm warning you, culture shift, because patients are frustrated, they're complicated, and it's very easy to say, well, I can't get through this guy, no matter what I do. So when I used to review charts on readmissions, it's amazing how the same treatment happens repetitively, over and over again. And on CHF, I wondered. So finally we said, well, maybe, you know, maybe we should pull in a cardiology consult, because it was very interesting how often they didn't, because the doc got used to seeing the patient, and they do the same thing, and they get better for a few weeks, and then they come back, and they do the same thing. So we bring in the cardiology consult, and they switch the medicines, and that sometimes really helps. Or they finally talk to the patient about what it was like at home, and how are they doing it? You know, CHF, the biggest thing is taking your medication. Why? Because those darn water pills were a real pain in the neck. If you want to go outside, if you want to do anything, they're a real pain. And so patients will take them. They stop taking them, just like our patients stop taking them. And you really have to engage with the patient and what that means, and maybe have them modify it a little bit so they can still have the lifestyle they want, but keep their CHF in control. So it's not just us. And if you think about your family members, I have family members who I argue with about taking, they're like, you know, they want to go, you know, because, well, I don't take it. And then sure enough, you know, they stop. So all I'm saying is we have to think wide, and we have to think that basically it's our responsibility to work with patients and to engage them. And it's everybody on the team's responsibility. So that's one lesson that I think, and it's more of a culture change than the thing. The second is complexity, complexity, complexity. I think almost every patient who gets into a hospital nowadays, I don't care on what service, is complex. They wouldn't be in a hospital. Now, if you broke your leg, you could probably get out easy. Maybe that one's an easy one. If you're young and you're going for a cholecystectomy and it's a, you know, a little procedure, you might be okay. But most patients who manage to get themselves into hospitals are complex and difficult by their nature. And they're complex and difficult on the discharge side. So you have to, I even don't like that word discharge. It sounds like they're out of our purview. Discharged. They're not discharged. They're still your responsibility. Critical, critical point. The challenge of working with these patients upstate is a challenge and an opportunity. I know that's hard. That's our reframing. What do you do with your patients when they're having trouble? I think we have to do that with ourselves. There's rarely one cause for a readmission. Every now and then there is. But I'm warning you, don't get sucked down the tube when you look at a readmission of an obvious cause. You've got to really talk to the patient. And what I would suggest, and I know this is time-consuming, I know it's hard, but we started in one hospital that was having a lot of trouble. We did a little mini root cause analysis almost on those readmissions when they came in. And that meant really talking to the patient, and really talking to the family, and finding out what didn't work. Unfortunately, it takes time. It's not something that you can easily guess at. So again, I would warn you, if you're having some trouble with some patients, sometimes you're getting a lot of them working with these problem ones, don't underestimate the time it takes to really ask somebody what is going on. My favorite example was a returnee to the ED who came back over and over again. And our case, we had case managers, you'll see this later on, in the EDs to prevent admissions. And actually, that part of our program, in 2 years, we prevented about 3,000 admissions across our network. So it can be done. But this guy kept coming back. He didn't need to be admitted, clearly, but he kept coming back and coming back. And he would come back with shortness of breath, and the doctors would look at things and they couldn't find anything. You know, so he became one of those patients. Oh, here he comes again. He would come every few weeks. And nobody really talked to him. So finally, our care manager got referred. So care manager sat down. It took a while to talk to him and try to understand what was going on. And what finally came out was that about a year and a half ago, we had had an episode of shortness of breath, didn't pay a lot of attention to it, and ended up hospitalized for 3 weeks for pulmonary embolism. And he was scared to death that he was going to get another pulmonary embolism. This was a guy who was going to his primary care doctor, but every time he had any kind of symptom, bounced back to the ED. And until you know that, and you can work with that kind of patient, and that's where he's at. It's not that he doesn't know how to take whatever medicine you've given him. It's not that he doesn't understand he should see his primary care doctor. He's got something in the back of his mind that's motivating him, the patient's needs and desires. What was his need? His need was to feel safe. He needed to have someone that maybe he could call when he had those symptoms and get him safe. And call and say, this is what I'm experiencing. Do I need to come to the ED? And somebody who knew him well enough to go, no, you can stay. You know, maybe you can come back. And those simple things can avoid expensive DED contacts and inpatient. So again, it's really, can't underestimate the importance of actually talking to a patient. The reasons why they don't follow up are complex, they're complicated, and they have to do with the individual. Don't ever underestimate it. Okay. The other is the system's just very confusing and very difficult. And I don't know. I mean, we're in the process of DISHRIPS. I am so hopeful that DISHRIPS will help us talk to each other and make our system less confusing and less difficult. But if any of you have tried to guide even a family member through either the mental health system or the medical system, and you become their patient advocate, you become the one. In the best places, you become the one who makes sure that this doctor talks to that doctor, and that the home care visit really happens, and who talks. Our system is unfortunately still very distributed, and I think that the district and everything will help with that, but it's hard. I'm telling you it's hard. So understand when your patients kind of can't navigate it, especially our patients who are maybe just getting out of the hospital after an acute psychotic episode. And you know, I still see some patients, but the patients that I've seen have been more, more the typical outpatient. But I recently had a patient who cycled into a manic episode. And I began to, I didn't get him hospitalized, saw him every day, got out of his manic episode. But it took a good year for him to really get what had happened. This was a very accomplished person who had his first manic episode, and how he was going to rebuild his life after that, what he was going to do. And we built some supports, and this was an upper middle class person. And for him, the trauma of having had this episode where he did some things with people that you're very upset about or ashamed of afterwards, and working with him to get really back into what was his life took more time. So now think of our patients who are so disorganized when they come in the hospital, and they know we're sending them out now without having been there for 3 or 4 months, or they're getting out in 15, 20 days. I mean, what was their experience? How organized could they possibly be in making sure that they take this medicine and that medicine? So you've really got to build supports around and understand just how disconcerting, even if the patient has been in the hospital multiple times, that experience can be. So I think that you have to build the support around it. We're going to talk about 2 key things. And then basically there's a real partnership. And we still have trouble. You know, I grew up, and again, I think maybe our younger docs see this differently, but I grew up still in the age where doctors' words were what is, were kind of golden. Didn't last very long. Okay, they were. So it's hard culturally sometimes for me to get out of that. But I'm telling you, if you're not engaged with the patient, if you don't really understand what they want, if you're not seeing them as a partner in care, not just someone that you're providing care to, but someone that you're working on the care with, it's very hard to prevent readmissions because these are complex, difficult patients. So you've got to kind of think about that. So what we did at our hospitals was we picked something called Project Red, which maybe I think we will be talking about a little bit later, which is an evidence-based thing on CHF, which really encompassed all the kinds of things I've been talking about, basically on the medical side, in terms of trying to reduce congestive heart failure. Key interventions are the things I've been talking about, basically, but you know, the team thing was critical. Throughout the hospital stay, everybody's talking about what could be your discharge, what would happen when you leave, what are your worries about when you leave, you know, it's fascinating. We often just don't ask point blank, what are you worried about when you walk out the door? Not what I'm worried about. I'm worried about you taking medicine, I'm worried about the get your housing appointment, I'm worried about the blah, blah, blah. But what are you worried about? And that's a critical question. You get an answer right away. Somebody will say, oh, okay, glad you asked. You have to really work with clients to come forward and say what they're worried about. What is it that they're concerned about when they leave? What are they really concerned about? Not a minor thing. The other big thing is to think about, I mean, when we talk about medicine, in our crazy, crazy system, for patients, sometimes we are prescribing things that they are not insured for. And, the worst thing that happens is when they go out, they go to the pharmacy, they can't get the drug, and now who do they call? Who do they talk to? And this, we just go to this one, is I find this the most important thing that can help you avoid readmissions. It's follow-up, but a key piece of the follow-up is who do I call if I have a question or a problem, and can I really get to them? And are they really going to know what happened to me while I was in the hospital, and can they talk to that to me over the phone? So, a 24-hour answering service where somebody hears and looks at the charge very quickly can answer some questions. But what works really, really well, and you're all going to say, oh, we don't have the time, we don't have the whatever, is for someone on that treatment team for the first 2 weeks post-discharge to be available to the patient. I'm telling you, it works really well. They know the patient's not afraid of asking the question. If they ask the question wrong, then you get crazy answer from the person who's on the other end of the phone, and then you get referred to the emergency room. And if your treatment plan is falling apart, you will know it early on. And that's the second key thing to follow up, is you've got to make contact as quickly as possible. They're all going to look at me and say, I don't have the staff to do that. People do it in different ways. You'll see from one of the hospitals that did it, they hire a caseworker to call the patient, ask a few scripted questions. If there's a problem, it bumps up to somebody else. Other hospitals, someone on the treatment team is responsible for it, and they give them a little time to do it. And you can say to me, and I know you're going to say, well, we don't have the time to do it. Well, I'm saying you can't afford not to have the time to do it, because you're going to get penalties and you're going to lose money. And this is what the if you don't do it, because you're going to have these patients coming back. So somewhere in the way you allocate staff time, and if you think about it, how many patients truly leave our units a week? About 100. There's nobody who can call the next day and say, how are you doing? Did you get the meds? Remember about your appointment? How are you settling in? We just don't see it. It's just fascinating. And when we did that, I will tell you, dramatic change in our CHF readmissions. And I honestly don't think it's very different for psych patients. I had my tooth out. My tooth out 7 months ago. Remember, called me the next day. I almost felt my dentist. Said, how you doing? Wasn't his secretary? You know why? Because he's not going to get the business if he's not making me happy. But still, I was shocked. I said, well, thank you so much for calling. And it was him. So all I'm saying is we have to think, this is a culture shift. Those first few weeks post-discharge, when do all the bad things happen? When do suicides happen? When do homicides happen? When do readmissions happen? When do people disappear so we can't find them? In the month after discharge. And some of them within the 2 days after discharge. And we put in all this effort and all this time, and we don't have the time. And they don't have a phone, get them one of those cheap cell phones. Get them, call. How are you doing? How can I help you? The simplest thing, a patient goes, picks up the meds at the pharmacy, and they're a different color because they're generic. They don't look like what they took in the hospital. They've got a funny shape. They don't look right. They can decide two things. They can call. Maybe they could ask the pharmacist, but often they haven't looked at it till they're home. Or they can call somebody, or they can get worried and wait and maybe not take it for a while. Or think, is this good? Or this pill's a little bigger than the one I had in the hospital. Should I take one? Should I take two? If you have a real ability to call and ask a question, and if you have somebody there who can answer the question, a simple thing like that can avert much, much more than you think. That's all I'm saying. Side effects. Medicine, side effects. You know, if anybody has ever been on a chronic med that you start in a hospital, and then you go home, it feels very different sometimes. When you're now trying to do things, you're trying to get around, you're trying to get your job done, suddenly the side effects are coming. You know, you didn't feel them in the hospital because you're in the bed and you rarely got up. But now you feel it. You don't want to take that thing anymore. So you need to talk to somebody about it. What's different? What's not working? How can we help them work with you? You can get them an appointment in 3 to 5 days in the clinic, but that clinic doctor, they may get the discharge report, but they didn't see the patient. The patient needs, I think, to have that support, that somebody on that treatment team, for a period of time, we do it a week even, can be a contact person for that patient. Don't underestimate the power of them walking out with a piece of paper that says, you have a problem, use this number, and somebody answers the number that can help. It will really help with cutting down readmissions. Okay. Then all the information has to go to the outpatient provider. You know, why again this is so hard, I'll never understand, but I used to try with my residents to say, you know, even just for a learning experience, why don't you call that outpatient provider, find out what happened before the patient came in? Why don't you call them and tell them what happens after they leave? You can send all the records you want, but if you're really worried about a particular patient, that call will make a difference. And just say it will make a difference. Still get all those records out, but talking to somebody and really explaining what's going on, and also hearing from them on the point of initiate, basically what was going on before. You know, when we got the more electronic medical records, people stopped ordering the charts. And in the transition point, I started to ask people, "How are you reading your own charts?" I didn't order them. I didn't know. So maybe the one last admission, or maybe no prior admissions for somebody. And so it's a culture thing too. The inpatient sees the patient, I hate to say this, and knows exactly what to do without talking to all those outpatient providers who've been struggling with these patients sometimes for years. Just think about it. You know, though having been more of an outpatient than an inpatient doc, I kind of know what it's like and how hard it is even as an outpatient doc when I had a bigger practice to get in touch with it. I don't have as much trouble getting to the inpatient docs, I think, as the families did sometimes, to talk about my patients. So think about it. Get that information. It really helps. Now, just to be clear about all these things that you'll see here that they did on Project Red, they also recommended, and this is where again people's eyes are going to roll, that there be someone on the team who primarily works with these kinds of connections. And they called it a discharge advocate. On the medical side, this was a nurse, high-paid professional position, which truthfully still is less costly than getting the readmission penalties on the medical side, which is why people are starting to use it. But in some of our hospitals, you know, we kind of couldn't do that. So we got someone on the team to be the point person, and we got the team as a whole involved. And actually that worked very well too. So on the evidence-based thing from Project Red, if you read it, you go online, you're going to see that they have these discharge advocates, and you're going to say, aha, that's why they can do it. And I'm suggesting to you that yes, that's a good way to do it. And I think for psych, you can do this sometimes with social work follow-ups, with contacts or nurse follow-ups. But I'm also saying to you that there can be variations on the theme here. The key thing is if you're going to do it with a team and not hire somebody special, somebody has to be the person who really thinks about this, and they will need some extra time to do that. You know, it would be that they can just do it on top of everything else they do. So you do have to think about personnel in this, but it's not as demanding as you would think, and the payoffs are tremendous. And if you're now in a district, and if eventually you're going to value-based purchasing, and some of what you get as an incentive, I know this is down the pipe, and this is the problem, is how do we transition from what we are now, which is fee-for-service, to what might be incentives. And we keep patients out, and we get some of those shared savings that will more than pay for having someone to do this kind of thing, I guarantee it. But I know right now we're in the transition. You've got budget people, and you've got people you have to talk to, and they don't What I'm saying is these positions that really work on the readmissions are very, very helpful, but you can do it without. If you really rethink kind of what you're doing with your staff, it can be done. It can be done. So now I want to go into 2 studies from 2 hospitals in your collaborative. And I think the main lesson as I go through this as to why they were successful is they didn't do just one thing or 2 things or 3 things to help stop readmissions. They did a whole host of things. Readmissions is a complex problem. It requires complex answers. So if you see and you walk out there and say, okay, we'll just do follow-up. I mean, I think it's critical. You've got to do the follow-up. But if you just do that, it won't work because you haven't really understood why the patient came in. And you haven't worked with the patient as to how to prevent them from coming back. And you haven't engaged with them. So that's not going to do it, just that. It's not going to do it just to get the medication right. That won't do it either. You have to have all these others. So when you look at these case studies of the ones within your group who've done it, what they've done is they've shifted the culture. They've done multiple of things to work with patients and have recognized the complexity of the issue and put some resources, shifted probably is my guess, some resources to make it happen. So the first one is from an upstate hospital with about only 54 beds. But, and then no psych, ER, or CPAP. So what they did was 2 critical things. They looked at the front end and the back end. And I can't emphasize this enough to you. You got to look at the front end and the back end. What's the front end? The front end is how patients get admitted to your hospital. How do they get in? When we put the ED care case management teams in the medical EDs, we stopped a whole bunch of admissions. And what we did was we screened every admission going on. And all those doctors had said this patient needs admission. Now, when you work with a doc who thinks a patient needs admission, you've got to go back to them and talk to them and wrap intensive services around them. This was not easy. They got clinic appointments within 1 to 2 days. They got home visiting nursing, etc., but they didn't get admitted. This is the same idea. However patients come to your ED and get in the door, or if they're referred from other doctors to talk to those doctors, you've got to figure out how you look at those patients. And most begin with a red flag for readmissions. And if somebody comes in, and most of us have some way of knowing if they've been there 30 days before, at least to your facility, that's the first group most people start to work with. And very intensively, see if you can avoid them going upstairs, see if you can keep them from going inpatient. You should really work with everybody who comes into the ED. Because most of us, unless you're very, very lucky, have different kinds of people shifting through the ED. You have different ED doctors. Sometimes they're your regular staff. Sometimes they're per diem staff. They may or may not understand all this or be into it. And they may be admitting patients in a way that is not what you really think is necessary. So you've really got to work with your staff who send the patients upstairs, whatever that form is. And you need to have certain ways that you can screen them and look at the protocols. Because remember, DSHRIP is readmissions and avoidable admissions. It's both. So they're not just looking at the patients coming back, they're also looking at the patients who's coming in for the first time. So basically, this is a critical point. And it depends on your system and how you do it. You'll see in the second case example, they found a different way to kind of do this. But this is the way they were doing it. And they had a cold stop where nobody with 30-day admission got in without the clinical director going down and taking a look. I mean, that'll get you power in terms of admissions. So you need something like that sometimes in the beginning. After people get the idea in the beginning, you know, we had to have a lot of push and pull. After a while, we had the docs coming to us saying, no, could you look at this guy? Because I don't think he really needs to be admitted. And if you could get these services, it took about 2 years. But we got them to be asking us, please help me. So this is a critical point. And I think you've got to look at your system. It depends on your system, but you've really got to look at what's coming in the door. Because you can do a lot of work on preventing them to come back when they're upstairs, but you can do a lot of work here. And usually the trick is having some availability of somebody who can do what I just said for the inpatient side. Call the patient, follow up, make sure if you send them home, they got what they needed. Some availability of using, getting into a clinic quickly, or getting a bridging team quickly, or getting a care coordinator quickly. A lot of work, a lot of work. Our system doesn't do this easily. So you've got to, it's hard, but it's hard to figure out, but I'm telling you, it can be done. But you've got to look at it. So they have a care coordinator. They funded a care coordinator. But there are these Health home people, another one. I think the health homes are getting better. And theoretically, they should be responsible for helping with this very kind of thing, which is a patient who ends up in the ED and what's going to happen. And that's the other thing our system, and hopefully Discharge will help with this, so that the hospital's not alone in this. If somebody comes into an ED, there should be a way, if you want to get them out with the right services, that you can easily get, a health home person, that you can relatively easily get visiting nurse. Post-discharge from hospitals, visiting nurses go to see psych patients. It's amazing how we don't use them. They're another pair of hands, they're another pair of eyes on a patient. And I would bet that most of you are not routinely sending discharged psych patients, giving them visiting nurse services. I had to get the medical people to do it from the ED. You can give medical patients visiting nurse services from the ED. They weren't doing it. They weren't thinking of it. It wasn't in their purview. We put a home care nurse in there to get the business, and they loved it because they got business. And that's what home care is, visiting nurse kind of home care is all about. So it's thinking about your system, thinking about getting the pieces of that system to work well with the ED. This is a lot of work, but if you stop it at the front door, you've got a real chance of really lowering your admissions significantly. Second thing they did was all the inpatient stuff I've been talking about. And it's not easy, but if you look at what they did, they didn't just do follow-up appointments, they did pretty much everything. They made the plan, they called medication access, they gave the pre-appointments, verified appointments, shared the EMRs, new patient supervisor, and followed up first appointment. They followed the clients until the first appointment up to 2 weeks. I'm telling you, that's the kind of thing that makes a huge difference. This is follow-up from the inpatient people. And if you can get a health home coordinator to do this with you, great. If you can get visiting nurses to do it with you seamlessly, great. But somebody who knows the patient and who has easy contact with the treatment team has to do this kind of follow-up if you're going to really be successful. And then they worked on developing their outpatient care to be able to accept these patients. One of the biggest issues we had on the medical side when we tried to avoid diabetic admissions, these are patients who came in with high blood glucose, was they would then go to the primary care site and the glucose was still up. It was a little high. And the primary care people got really nervous. They sent them back to the ED. So we had to work with the primary care doctors. We were going to be sending them patients that were a little sicker than the usual well-care appointment. And they shouldn't be sending them back to the ED. And that we'll work with them on supports and we'll help make sure the visiting nurse service is there. When we did that, we were more successful in getting our patients from the ED. So it's the same thing with psych. If we don't have, and this is something that we're going to be looking at the state, is some variant of intensive outpatient, something where patients who are just out of the hospital get a heck of a lot more than the patient who comes in for an anxiety disorder. And the way our system has worked often is you get the clinic appointment and you fall into the same mode. Maybe you'll get seen a little more often. Maybe they'll say a weekly appointment, or maybe you'll get a social worker, but you may not get may not be seen as, just came out of a psych hospital, therefore should get, at a minimum, blah, 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 blah. And you've got to start thinking that way. If you've just been in a hospital, we all know how hard it is to get into our hospitals. If you have a minor problem, you get into our hospitals when you're on the brink of something really almost catastrophic. And then you leave, and sometimes we have ACT teams, that's great, if we can get them. I know it's hard. But even ACT teams aren't going to be there for everybody. So the patient who doesn't need that needs something. So we need to think about our clinic systems. And I know some of you have been doing this. Some of you have been putting those services in. But it's a critical point. These guys did it, and it helped, because then the clinic could keep track of what's going on. And then, so the readmissions went down. And they went down pretty dramatically. Second example is in New York City. Very busy HHC hospital with a CPAP that basically did all this very similar things. They used their CPAP in a different way. I honestly have to say that for many years, I didn't use my CPAP very well at Elmhurst. We didn't really use those beds, observation beds, as much as we should have. We didn't connect all that well with our crisis teams, but I know now that they are. And we didn't because we always felt we were too busy, and we probably ended up over the years admitting lots of patients that we could have diverted. CPAPs are actually very rich services, but I don't know that they've been used as well as they could be. So it's something to consider. So they also connected with partial hospital staff Respite beds, one of the things we're going to be putting up, we're still working on the model, is a respite bed that has more medical coverage to it, so they could be used more easily as admission diversion than classic respite beds, which has very little medical coverage, so people are very reluctant to often use those respite beds as admission diversions. So in the new HARP dollars, we're looking for a higher intense respite bed and how we will fund that and what that will look like. So that basically some of these patients would wrap around and could maybe go to a respite bed and then stay out of the hospital. So variations on the theme here, but basically, again, you go to wherever your entry point, your door is, and you figure out how to be as successful as you can for patients coming in. Again, flagging readmissions, that's basic number one. You don't do anything else, flag the readmissions. You take a look at them before they get upstairs. And sometimes they will need to come upstairs. I mean, I'm not saying that all the stuff I'm talking about you can always prevent it, but I do think that you can probably prevent it more than whatever you're doing now, if you pay attention to these things, okay? And then this concept of real case conferences, when I was first trained, we had probably more case conferences than anything else. It gets lost somehow in the busy day, and all I'm saying is sometimes the time spent really having everybody talk together with the patient and the family and figuring out a really solid plan is time well spent. The primary care people will tell you the same thing. I don't have time for this. I can't get all this stuff that you want me to do. The medical people will say the same thing. But there are patients where you really got to pull everybody in and do it, and it can make a big difference. Don't underestimate it. And it's not time poorly spent. Maybe in the past we did it a bit too much, but now I think we're doing it way too little. And I think sometimes you really need to get everybody involved just with that patient, try to figure out what the heck isn't working. And then together work about how you can fix it. And again, short-term, some variant of short-term follow-up. You know, if you've got the staff and you can do it, the longer the short-term follow-up is, in some ways, the better until the patient's engaged, but some degree of short-term follow-up that is the responsibility of the inpatient discharging service. I know that sounds hard for some people, but I tell you, if you don't do it, you really lose something that's golden here in terms of trying to keep the patient out. Warm handoffs, outreach, all that kind of stuff. Engagement in aftercare. They had good success, and they had ultimately great outcomes. So stop there, but I hope it kind of just sets a little bit of the stage, and I wish you all luck. Don't be discouraged. I can tell you it took us a while to get there when we were working on CHF, but after about 6 months, it started to drift the other way, and then we had a kind of stage decline, and eventually it'll level off. You know, you can't get rid of all readmissions, but I'm telling you, it can work, so don't get discouraged and learn from others. You know, if you want to talk to those hospitals that are up there, ask the collaborators. Learn from each other. Thank you. I've solved it.
Hi, thank you very much. In your opinion, and based on your knowledge, do you think there's any room for any regulatory relief in all of this?
I tell you, which kind of regulatory relief are you thinking of?
Well, from OASIS regulations, OMH regulations, DOH regulations. Yeah, I mean, we really live under a lot of regulations. But if you think there's room for that, what would you look to change?
Okay, a couple of things. I think when we got the DSHRP applications, we got a lot of requests for waivers for the collaborative care stuff, and we're going to work very hard on pushing as many of those through. So that's where basically you can co-locate substance use and mental health, and co-locate substance use and mental health primary care, co-locate primary care with substance use and mental health. And there's a lot of good possibilities in there in terms of waivers. The other interesting waiver, which I hadn't thought of, was waivers for crisis teams, because we have a kind of peculiar way that we overregulate where they can do, what they can do, their involvement with EDs, the very thing I'm talking about. So we got some interesting waivers there through DSHRP, which I think will make us rethink what we're doing. The other thing we're rethinking, and again, I don't promise how quickly it will come, is I think ACT teams are wonderful, and I think that sticking very closely to the model is important for some patients. But we need something that's not quite just that. So I know we're thinking about how to either try kind of transition out of ACT, other things that could work, lowering some of those tight regulations that sometimes keep people stuck in places. There's a whole bunch of stuff around admission to housing, which I won't go into, which I've just found out recently, in terms of how you fill out certain forms. You have to work on some of this because it kind of prevents certain things from happening. So I think we have to look at the regulations in terms of integrating services. You know, how can crisis teams go into medical EDs and get paid for it? Right now, there's no way for a crisis team to sit in a medical ED, which suppose a hospital doesn't have a psych service. I mean, to me, the thing that makes the most imminent sense is you should put those crisis teams go in there, work with the patients, let them do the discharge planning, let them work with the team and take the patient out. Not easy to do. Not easy to do with the way we regulate. So those are the kinds of things we're looking at. I know there's also charting things that people sometimes are trying to think about simplifying some of that. Access to clinics is a huge issue. That's not so much regulation as trying to keep the clinic systems stabilized at a time when there's a lot of instability. Most of the hospitals depend a lot on the Article 31s, and we're well aware of what's happening with the Article 31s, and we're trying to see how we can help stabilize. We have a BAP program out to give some dollars to help stabilize the clinics. And so there were lots of questions from some of the clinic providers about relief of documentation stuff. Inpatients, you're kind of stuck by and large because you've got CMS looking over your shoulder about everything, and they have pretty high. So there's certain things we can let go and certain things that are CMS actually that are beyond our control. So those are the kinds of things we're looking at. And if you have other ideas, please let me know, email me, tell me what you feel in the regulations is the way we do them that hamper the kinds of things you're trying to do, and we'll see what we can do. Because I do think simplifying the regulations is very important. Some we can, some actually we can't, because they're CMS, they're not state. But let me know if there's anything that you think. Yeah.
I just had one follow-up question, and the whole issue of regulatory change and urging integrated care and all that. I got a little feedback from reading here that although we're looking in that direction for the clinics, the billing is still not integrated, and that I just wanted to see some follow-up on that, whether if, for example, we had an outpatient program with integrated medical together, whether we will also be able to bill in a consistent way without following.
Yeah, we're working really hard on that. We're going to be working on, maybe Tom, why don't you answer?
I think. Hi everyone, I'm Tom Smith. I'm with OMH. I know many of you. Related to the billing question, I think one of the points I wanted to make is that is related to cost and payment for these services. Anne talked about a lot of innovative practices. Mark talked as well about things that can be done to improve care transitions. And it came up a couple of times that these are expensive things and they're not paid for, and these are unfunded mandates, et cetera, et cetera. So I think the point I want to make is that now is the time for us to take advantage of opportunities to get these practices paid for. There's three major new reform initiatives going on in the Medicaid program: DSRIP, health homes, and the Medicaid managed care. So think about this. DSRIP, there's $6.5 billion out there flowing out to the PPSs for healthcare reform. These very kinds of activities. Hospitals and PPSs, and you guys a lot of you are the PPSs, are going to have a lot of authority about how those dollars are spent. You have a perfect opportunity, the people in this room, to present projects and activities to your PPS leads related to care transitions and behavioral health that cost money, whether it's intensive care, transition teams, et cetera. The DSRIP dollars are supposed to support that. So come up with ideas, tie them into your PPS proposals. It's not too late. I think there's going to be a lot of flexibility about how those DSRIP funds can be spent. So take that initiative and say, these are where the dollars are supposed to be spent. Health homes. No one's mentioned health homes yet. We're 2 hours in, right? They've been at it for a couple of years now. It's been a rocky road. It's an evolving program. It's going to continue to evolve. I think the onus is on us to help shape how it works. If you look at the health home provider qualifications, one of the key 6 areas is care transitions. There's very clear language in the regs about health home care managers coming onto hospital units to visit, high-need, high-risk populations and facilitate those transitions. So develop the programs that, develop the algorithms that identify people that get flagged in the system for immediate notification of the health home and get that health home care manager there. A lot of kinks to work out, but that's the vision. The dollars are there. The resources are out there. Let's get them alive. And last is Medicaid managed care. And we did invite several of the managed care plans to join and get involved in this collaborative. We're folding all these behavioral health services into the Medicaid managed care plans and the HARPs, right, starting this summer. We're working furiously with the plans on our vision and operational approach for a new kind of managed care that's not just medical necessity focused, it's person focused, and it's about continuity of care. All these same vision and principles we're hammering home with the plans. So the plans ought to be very interested in hearing your proposals about innovative care transition practices that would decrease readmission rates, et cetera. And I imagine and hope and expect, for all the plans in the room, that the plans will be interested in helping pay for them. So now it is a different time. There are resources out there now to pay for these things that we've been talking about for all these years, but really weren't able to pay for. So please take advantage of that and be assertive and clear with your proposals, ideas, and push.
Just to echo what Tom's saying, been able to kind of keep talking, with you guys. Although the plans will be submitted, it's one of the technical assistance is going to be out there to help the district providers. And we've gotten about 2 or 3, which isn't a lot, across the state that have done a lot of interesting stuff with crisis teams in the district. Not as many as we hoped to come in from behavioral health, but they're out there. And so it's a possibility. And some of them are quite innovative and they'll be investing in this kind of crisis expansion service to help with the very thing that we're struggling with here today. So it depends, but keep looking at it. I think that there are some models, yeah.
Yes. My question is, our facility has gotten better at looking into psyches, and you get a lot of information from psyche. But our patients are also getting much better at saying, not providing consent. We have had an increase in patients saying, no, I'm not going to consent to that. I don't want you looking. Is there any movement of that we're going to continue to need consent, or it's a billing system, and it does provide a lot of information where you can flag the at-risk readmission and so forth, and patients are getting very savvy. I can try and jump in and address that. For hospitals, particularly in the emergency room, we suggest that if it's folded into the admission packet and it's just routine care, that makes it a little bit easier. I know you'll still find people saying no, but there's so many things that people coming in for care, they release for HIPAA, release for billing, There's a lot of things that they sign. If it could be folded in as here's the things we need to do the best care for you, and that, how can we treat you if we don't know what's going on? So we're folding it into routine processes and not pulling it out like, are you sure you really want me to look at your Medicaid data? So just, okay, so the other is people coming into the emergency room who are experiencing a clinical emergency. There is an option for you to go into psyches and attest to that. So you can go in and say, this is a clinical emergency. That will give you a 72-hour access to pull down. So, clinical emergencies can happen in any setting, but they're probably more likely in emergency rooms. And then the third option is that you can attest that the client is in your care, that the client is presented to you for care. It's not the same as a consent, but you're attesting that the client is in your care. If that client happens to have a quality flag, you will then get almost all of the data because you, as the provider, are entitled to be aware of what those quality concerns are. So this is something I can see by the expression that it's something that maybe we could do some training around so that people understand what these options are. Because we have heard that from others that as people realize, like, oh, this is a tool that helps you realize I've been to 20 hospitals and asked for a lot of prescriptions, that some people have said, I'd rather you didn't know. So we'll do some training around that because there are some options.
I always admire your common sense, and I'm thinking it's an obvious idea to have the inpatient team do the direct follow-up of our inpatients when they become outpatients, and how we would make time to do that. And the question was about changes in regulations. Could the treatment plan, which required multidisciplinary treatment plan, perhaps be rethought as something like or allow, so much information is now captured in the daily progress notes. Admissions are 3 to 8 days, not 3 to 8 weeks. That's time, valuable time that could be used actually in providing follow-up calls or discussions with the emergency room or whatever else it would take to.
No, I think we can rethink it. You know, we started on the outpatient side to try to talk to people and get some feedback. And I think we can rethink some of that. I think what you're asking is the burden of some of the documentation. But the only thing to just keep in mind, as we really even looked on the outpatient side, a lot of that sits, some of it is us, and but a lot of it sits with CMS, so you're stuck a little bit. But what we will work with, we started with outpatient, we'll start to look at inpatient and see to what extent some of it can be simplified and made easier. I agree with you. I think that it's burdensome at this point. But you know, we have to push it past a whole bunch of payers. Some of it, but we can work on it. We'll work on it. That was, you know, we started with outpatient, but we can work on inpatient.
Hi, good afternoon. How are you?
Hi.
Please speak directly into the mic.
Good. Can you hear me? Or no? Yeah. No. Yes. 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 Okay.
Right.
That's Dr. Cuyo.
And just a question in terms of the possible integration, if I may say so, between OASIS and OMH in terms of regulations, because that is really interferes in terms of integration of services. So just have your comments on this.
Yeah, I think we're going to be looking very closely at the regulations, and we're going to also, over the course of this year, we're going to be working very closely with OASIS on how we can really make both agencies work better together. Part of it's regulations, but part of it's all kinds of things that we do a bit in silos. For example, you know, how do we kind of just talk more to each other? How do we, when we go out to talk with you, have people who know both sides of the house? You know, so I think we're going to be we've been asked to do a report on how to better integrate both the regulations and the service delivery and the agencies this year. And we'll be asking for lots of stakeholders in that. Some of that will actually be from the hospitals. And that we're asked to kind of spend a year getting feedback and then get a report to the governor's office early next year. So I think we're going to try to look at all the pieces of the puzzle and I think see how we can, you know, in many, many states, they've really broken down the walls between these agencies, and we have to do it right. You know, you can't, many of our issues overlap, but there's also probably some substance use issues that don't really overlap that much, and some mental health issues that don't, and some services that do and don't. So I think it's wise to give us a year with lots of stakeholder input from you to figure out how, at least at the state level, we can do a better job of this. And one of the big goals is those regs. I'm telling, is the regs.
We'll give you 2 years, huh?
Thank you. We gave me another year.
Thank you very much.
I'll take it. I'll take it, please.
Thanks, Commissioner, for a great talk, as usual, and I really like your emphasis that we have to focus down on some of the most difficult patients, and the answers are highly individual and time-consuming. That said, I wonder, you and I, I'm afraid, are old enough to remember what ACT teams were meant to be, and they were meant to be an extension of the hospital for 30 to 60 days after discharge. And they have morphed into something totally different that is necessary, perhaps. And we lost there, and yes, we're trying to rediscover ACT. And we are in this interval period where we're going from being paid for services to being paid for patient outcomes, quality, and all of that. And we're in that for the next 2 to 5 years, unless district funds really are enough. But, you know, there's going to be a lot of competition. Your friends who do congestive heart failure are going to want the transition care managers. And whether we get them or they get them, I think I know the answer. I think it would be helpful to look at not just so much regulatory relief, but the creation perhaps of CPTs for billing for these care transition intensive services that I think are extremely powerful. And then, if we could do that, we could have a business plan to sell in the short term for creation of these teams, or in our case, expanding the mobile crisis team to do these things. I wonder if you could comment on this.
Yeah, I think, I think we've got, with opening up the HARPs, which is a lot of actual money that's coming into the managed care companies, and they're now going to have almost everyone has bought into having a behavioral health division and a behavioral health leader. There's a lot more attention. So what we're going to try to do over the first 2 years, rates are going to be held pretty much the same for those first 2 years on all the outpatient stuff. But we're going to be redesigning over those 2 years what would be reasonable things for managed care companies to pay for the kinds of things that you're talking about. Now, it might not be the same thing as a CPT. I'm not sure exactly how it's going to come out, but the concept that, if you do this, this is worth $200, and if you do this, should be the average price should be $100. And we're going to be working, hopefully, with you guys as we develop this over these 2 years as to what those things can look like. I think that things like ACT, just to take that for a minute, we do have our best practice people up at Columbia looking at a way to work with our ACT teams to transition patients out of ACT. Not a minor issue, because people kind of we're people, so we get into doing certain things certain ways. And we're also looking at what intensive outpatient might look like, what might be the cost for an intensive outpatient program, what might be an ACT light kind of thing, where basically some patients who don't need the whole thing, and what that might be. So we are looking into those and how you price them. Now, you can't control the pricing quite the same way, but I do think that the managed care companies are working with us on this, and they're definitely interested in getting these kinds of services going. So those intensive aftercare services are things that we really have to figure out. We did get some money in the budget to follow up prison discharges from the state system's prison discharges. And what we're going to be putting in place are ACT services wrapped around housing for the very high-risk patients with a approximately 9-month limit. So they're going into it with the idea that we're talking about, that these very intensive services, now some patients may need a little longer, but these very intensive services are time limited. And we've had good results with that with the prison discharge patients. We haven't really done that model in the same way with patients coming out of hospitals, but I think it's something to look at. In other words, they have all the bells and whistles of ACT, but it's kind of time limited and focused on getting you really stabilized in the community, and it's linked very tightly to your housing. So I think it's a nice model for all kinds of discharges. This one, we just got some incentive money to kind of put it up, but it's a similar kind of idea.
Thank you. I was listening to you talking about culture change, especially when you're thinking about limiting readmissions on the front end. And I'm just wondering how people thought about risk assessment on the front end to help with the managing or limiting readmissions. And I'm just wondering how people did this in the hospital.
Yeah, it's a big issue. It's probably the biggest issue with the docs and the providers in ED. Again, it's fascinating because people in EDs only see people in EDs, and people on inpatient and inpatient, and people in the outpatient are much more comfortable with working with people in various stages of crisis for a long period of time. But EDs, the risk factor, if I let them go, will there be a suicide or will there be a bad event? It takes a while to work with the staff, and you have to build their confidence. So you probably don't, the most difficult patient isn't the first one you send out with these wraparound services, but you send out somebody who's a little shaky. It works. You get back to the doctors and you tell them, hey, this works, Mr. Jones. And that's what we did in the medical EDs. They told us we're going to kill patients because they're going to go out with these high blood sugars and they're going to die. And basically, we didn't kill anybody. But we had to have the confidence of the doctors that we were going to really wrap the services around those patients. And if it didn't work, they came back to the ED. And we did have about a 5% that came back. because we couldn't wrap it around them, we brought them back or got them back into the ED. So, but it's gaining that confidence and helping them to see things through a different lens. Now, it's, on the inpatient side, I can tell you on the psych inpatient side of the state system, we have a very maternal, paternal attitude towards our patients. It's very hard for them to see things leaving. You find that hard because I know you get. But we have some long stayers who we've never been able to, and so it's again shifting the culture a little bit. That maybe these patients can make it outside if we give them the services wrapped around. Now, the individual doctor is still going to have their individual liability. But what's interesting is, if any of you do outpatient, you've always got that liability. I mean, I used to see suicidal patients all the time. I didn't send them all to the emergency room, And sometimes I waited. I did, I didn't. ED doctors are a little bit better off because they always have that backup of sending them upstairs. But it's not a safety valve either. Believe me, they send out enough patients and things still happen. So you've got to really work with them though. But it is a culture shift. It is a risk. Adversive because people are afraid of being, and believe me, I'm a doctor, afraid of being sued, afraid of all the bad things that can happen. But you also have to think a little bit about what's really best for a patient. Is admission always really the best thing? I mean, are we saving our backs, or are we kind of doing the right thing for the patient? Because multiple admissions is not a good thing for most patients. So maybe they need it, but not. Come on. So we'll really be more protecting ourselves than the patient. So it's a shift. And you got to work at it. And the biggest thing is when they see that it works. So you got to kind of have a few wins in the beginning. So I wouldn't suggest you take the most problematic patient and do this, but you get those wins going, and then people buy in. Any other questions? Okay. Thank you. Thank you.